How did that even happen?
I believe all permissions for recording have been granted. If you requested permissions in the chat, you should now be able to record. If you still need permissions granted, please leave us another message in the chat so we can make sure everybody's been taken care of. Dr. Vanderhoff, we will now hand it over to you to begin today's press conference.
Well, thank you. Good morning, and we appreciate you joining us today. I'm Dr. Bruce Vanderhoff, Director of the Ohio Department of Health. There is light at the end of the tunnel for us in Ohio. We are continuing to see many signs of improvement in some of Ohio's first and hardest hit areas during this dramatic surge in COVID-19 cases, which of course have been fueled by the Omicron variant. Just 1 month ago, Greater Cleveland and Northeast Ohio were at the forefront of Ohio's Omicron wave. No previous variant spread nearly as fast as Omicron, with reported coronavirus cases rocketing up from about 7,000 to 8,000 new cases a day in early December to more than 20,000 cases a day now. As these cases skyrocketed, record numbers of people headed to the hospital for testing or treatment, crowding emergency rooms, filling our hospitals, and forcing postponement of many elective procedures. The Ohio National Guard was in fact called in to help, as was the U.S. Air Force medical team. Statewide, hospitalizations reached a pandemic high earlier this month and have been steadily dropping for the last 16 days. Ohio hit a record 6,749 hospitalizations on January 10th. And that number has been falling daily ever since and now stands at 5,004. That's a 25% drop in just 2 weeks. That drop in hospitalizations has been the steepest in Northeast Ohio, where hospitalizations are falling just as quickly as they soared. Despite these encouraging signs, our hospitals in Ohio remain challenged. While our partners at the Ohio Hospital Association have reported a continued overall decline in total COVID-19 hospitalizations in recent weeks, many hospitals continue to struggle with high hospitalizations that are approaching their capacity. And many regions have overnight elective surgeries postponed or canceled due to the high volume of hospitalizations. The Ohio National Guard remains instrumental for our clinical and non-clinical support to ensure healthcare services are able to remain responsive to community needs across our state. Omicron is hitting Ohio in waves, and right now, Southeast Ohio, Southern Ohio, and the Dayton area are seeing increases in hospitalizations. So, have we reached our Omicron peak? Well, it's a yes and no, depending on where you live. In greater Cleveland, demand for COVID-19 testing has dropped substantially, allowing National Guard resources to shift away from a testing center and in-hospital support there to meet emerging needs elsewhere in the state. At the Cleveland Clinic, a team of 20 medical personnel from the U.S. Air Force are integrated into daily hospital operations, offering daily staffing support and allowing the Cleveland Clinic to bring in transfer patients again, which is a critical piece of the clinic's promise to provide critical care to patients well beyond the city of Cleveland. While perhaps not as dramatic, there are also signs of improvement in places like Greater Akron and Central Ohio. But in Western and Southern Ohio, it's a different story. Today, we're joined by two physicians from two areas of Ohio that are still feeling the deep impacts of the Omicron surge. First, we're joined by Dr. Brian Kaminsky, the Vice President of Quality and Patient Safety for ProMedica in Toledo. Dr. Kaminsky is here today to share a bit about how Northwest Ohio and the Toledo area are continuing to feel the effects of Omicron. Dr. Kaminsky, Toledo was one of the first parts of Ohio to actually experience the impacts of Omicron and continues to feel that impact. Can you reflect on what you're seeing as this variant has made its rapid spread through your community right on the heels of Delta? And what has the impact been on your hospitals, patient care, and are you beginning to see any signs of relief?
Sure. Thank you for asking me to be on, Dr. Vanderhoff. I appreciate being here and having this opportunity and to share our story. What you've said as it pertains to Northeast Ohio is really similar to what we are experiencing in Northwest Ohio, but maybe just a step behind. So it feels like, you've had, experienced 16 days of continuous declines in the Northeast. We're maybe a week behind that, maybe 7 days of continuous decline. So we're experiencing, a mixed bag in Northwest Ohio. And as we're all looking forward to this point in time when we see a true reduction in all of those metrics that we look at, hospitalizations, deaths, patients presenting to our emergency rooms and our urgent cares in our offices, we have mixed data right now. So we're definitely encouraged by the fact that the burden on our emergency department and our urgent cares seems to be reducing right now. We also have had significant assistance from the National Guard, and we have a National Guard presence right now that is helping with a lot of those functions that you've described. So they're integrated into our hospital and our system, allowing a lot of those ancillary tasks to be fulfilled while we continue to maintain operations. There is data that still hurts, and it still is applying stress on our system right now. So just last week, we recorded our highest number of deaths across the system. So that's really unfortunate when you look through the waves of pandemic that we've been through. So in many respects, this is and has been the hardest wave that we have gone through. The volume combined with nursing challenges and staffing shortages has really taken its toll. And just the demand for testing during that time period when Omicron was spreading like wildfire. And it seemed like everybody in our community needed a test, wanted a test, and some of those just were otherwise doing well and were going to recover at home. But many of them ended up entering into our healthcare system and, occupying beds. And we're still at about 90+% capacity for all of our hospitals. But there is light on the horizon. The number of people entering our hospital is continuing to reduce. And we all know that the amount of patients in the hospital, and especially those in the ICUs, tend to remain for a long period of time. So the stresses definitely aren't over, and our healthcare force is still feeling that stress with wave up on top of wave. But we're definitely feeling optimistic at this point that because of the fewer patients entering our system, that we are starting to get ahead of the curve, and we're going to see some improvements.
Thanks. I want to follow up a little bit on one of your observations. What would you say has been different about Omicron in terms of its impact on the hospital, the kinds of symptoms you're seeing with patients, length of stay, recovery, et cetera? And what's been the same?
To me, the thing that feels most different right now is we really have two different populations of patients. We have patients who are coming in and experiencing a breakthrough case that have been vaccinated. And by and large, those people are all doing very well. It's rare that we see somebody that requires hospitalization that's been fully vaccinated and boosted. And when that happens, it's usually somebody with significant risk factors that impairs the immune system from responding appropriately. And then the second population of patients that we have is those patients that are under or unvaccinated. And it's those people that remain at risk. There's a lot of discussion out there, and you'll see news headlines saying, Omicron is less severe. And, while it might be slightly less severe, this is still a deadly disease in a large portion of our population for those people who have risk factors. So we're definitely seeing people very sick with Omicron. It's just really two different buckets that we're dealing with now, and we didn't see that with the initial waves. And so I hate to see, the scenario that could have played out if we didn't have an effective vaccine. So really, that's the most striking difference to me.
Yeah, and as you've noted, even though we are seeing signs of improvement, your hospitals are still incredibly busy. There's a lot of demand for healthcare services. So I think it's important. Could you share a little bit about your perspective on what people in the community can be doing to not only keep themselves safe, but also ensure that our hospitals, in fact, aren't reaching a point of becoming overwhelmed again?
Well, first and foremost, it's not too late to get vaccinated. The disease is still there. Although we're talking about improvements, it's still here, and it's widespread, and it's prevalent, and it's out in our community. So if there's anybody who is still considering vaccination, that is the number one prevention strategy that definitely is going to help us, get out of this wave, and then, prevent similar stressors in future waves. In addition to that, all those preventive measures are still helpful. So we know that Omicron is more contagious. So there is guidance out there about more protective masks. So we're advising, N95s or those multi-layered masks as an alternative to cloth masks. And, when you go out in public, it's a minor inconvenience, but it definitely helps our healthcare workforce and helps us manage this, large influx of patients that we're dealing with. So number one would be vaccination. And number two is still those preventative measures that we know that has helped mitigate the strain on the system with previous waves.
Thank you very much, Dr. Kaminsky. Next, I'm joined by Dr. Stephen Fagans, Chief Clinical Officer for Mercy Health in Cincinnati, and also Hamilton County Public Health Medical Director. Dr. Fagans is here to share a little bit of the perspective of Southwest Ohio, including the Cincinnati region. Dr. Fagans, Omicron has, as I noted, made its way across Ohio in waves. And right now, you're certainly in a portion of Ohio that is still feeling a substantial impact from Omicron in terms of COVID caseloads in your hospitals. Can you share what your hospital system and others it works with are experiencing right now in terms of COVID hospitalizations, and a little bit about how your staff is coping and managing the caseload and challenges?
Well, thanks, Dr. Vanderhoff, for asking. And, as Dr. Kaminsky was talking, Southwest Ohio is probably more like 2 weeks behind the Northeast. And as you see it coming across the state, we were able to see that. We have the luxury of having all the health systems meet together every other day and look at our numbers and look at our capacity. And so we peaked in January of 2021 at about 825. We're well at 1,000 today. We've been at 1,000, almost 1,000 patients among our hospitals for about a week or so, just under 1,000. And so, as you look at the curves, you described it very well. It was an Omicron on a Delta surge. We still had plenty of patients, and still do, 20 and 30-day length of stays in the hospitals that are probably Delta, that are still on ventilators, still struggling, still there. And then you add a highly transmissible, highly prevalent, fast sort of Omicron onto that, and you increase the admission rate. The sort of good news is that if you look at the proportion, so we were around 800 peak with about 200 peak ICU in the last surge, and we're about 1,000 peak with still 200 ICU in this surge. And what was said about the vaccine is even more apparent with Omicron. The effects of, we began to see what we thought during Delta is an increase in patients that breakthrough cases, if you will, and perhaps it was a number of months or so after the second dose, but nonetheless breakthrough cases. And so with boosted individuals, you don't see as many breakthrough cases, and you actually see less severe, and that's been our anecdotal evidence. We've been looking at these curves now for 2 years, up and down. There's a fourth curve. We look at the total hospitalizations, we look at ICU, and look at ventilators. The fourth curve is staffing. And so Omicron has really brought that to the forefront. When you have 33+% positivity rate in a community, 1 in 3 people at least, including hospital staff. And so as we look at the curve, we've probably been stable now for a little over a week, maybe starting to trend down. It's certainly trending down in admissions, but not yet trending down in hospitalizations. Same thing with staff, delayed by the 5 days, which we're very happy that be able to have that so we can schedule for that next shift. And so the staffing curve, which really complicated early on, a few or 3 weeks ago, as we, the surge in the hospitals combined with that, really caused a struggle. And so staffing starting to, those that have completed the 5 days coming back in, and fewer call-offs per shift, both all hospital systems here. You did mention the National Guard, and so we here in Southwest Ohio early on really focused on using National Guard in our mass testing sites. The rush to the emergency department for testing was significant, a significant burden on the emergency departments. And that has really been dissipated by the ability to have 4, now 5 mass testing sites staffed by Ohio National Guard has helped tremendously. And those sites are we're able to send people there, get a good solid PCR test. There are some of our hospitals here locally they're using Ohio National Guard both clinically and non-clinically. The Mercy system hasn't yet done that and probably won't. But nonetheless, we talk together. We understand how staff can be used, and we load balance patients when we need to. We did take some patients from the northern part of the state, not that many, during the significant surges there, and appreciate the reciprocity if necessary when we're here. And that's just the benefit of us talking as a region, as a zone, and as a state.
Thank you, Dr. Fagans. I'm going to ask you the same question I concluded with Dr. Kaminsky, and that is, look, what are some of the best steps Ohioans in Southwest Ohio can take right now to protect themselves, their hospitals, their communities?
And it's one, being thoughtful. The Omicron variant has even made vaccination more important. And what had become sort of fully vaccinated at 2 doses has become an up-to-date, a 3-dose. And so being up to date, if you will, on vaccination, it's never more important. Even if the transmitting variant may seem less virulent, it's incredibly transmissible. But also thoughtful mitigation in terms of being out and about and wearing masks. And when ill, stay home, just like we always have, our grandmothers taught us to do. And so those types of common sense are coming back, and we want to talk more about that. And the other is, all of our hospitals have a mask requirement when you come to visit, not just a cloth mask, but we give you a good medical grade mask. The type of mask is important, as well as just the sort of social distancing and other things that you've talked about for 2 years.
Thank you. Thank you so much, Dr. Fagans. Well, there's no question that Omicron has hit us hard this winter, coming right on the heels of a large surge that was driven by the Delta variant. but we're cautiously optimistic that we may be reaching the other side and beginning to head down from this peak as we head into the month of February. We've seen Omicron emerge fast and furious with sharp rises and steep declines in other parts of the world. And that is also what may be starting to happen here in Ohio. But let's take a moment to pause and put all of this into perspective. Even when Omicron does finally peak in all parts of Ohio, we are still going to be a long way from the much lower levels that we were seeing last spring and summer. Make no mistake, case numbers remain in all parts of Ohio incredibly high. Throughout the pandemic, cases per 100,000 residents is a metric that is proven to be a useful measure of the level of infection and spread in our communities, both when cases were high and when they were relatively low. Last July, we hit a low of 19 cases per 100,000 persons. This week, even after some of the declines that we've described, that number is still more than 1,700 cases per 100,000 persons. Now remember, the Centers for Disease Control and Prevention defines high community spread as anything over 100 cases per 100,000 persons, and we're at more than 17 times that. This shows that we still have a very, very long way to go before we're back to where we were early in the summer. Now, managing such high case volumes has unquestionably placed stress and strain not only on our hospitals, but all of our communities, from businesses just trying to have enough people to stay open, to teachers and students trying to stay in the classroom where they belong. And our local health departments have been working tirelessly to keep up with their important role of mitigating community spread of COVID-19 through case investigation and contact tracing. As COVID-19 has evolved, public health mitigation strategies have had to adjust periodically to address new challenges posed by a changing virus. The quick spread of the Omicron variant and its rapid clinical course, in fact, have made universal contact tracing, case investigation, and exposure notification impractical and less impactful than taking a more targeted approach. And so yesterday, I shared a memo with local health departments and K through 12 school superintendents updating recommendations regarding contact tracing and case investigation to prioritize and focus that work on clusters of cases or outbreaks, as well as on very high-risk settings, such as congregate residential settings like shelters, correctional facilities, and nursing homes. While this will relieve our schools of some of the burden associated with universal contact tracing there, it's important to note that our K through 12 schools will continue to follow our mask to stay, test to play guidelines, which have been very successful at helping students remain in the classroom safely. And our schools will continue to submit case reports to their local health department, with those reports now updated weekly for public viewing at coronavirus.ohio.gov. Guidance for the general public about what to do after testing positive for COVID or after being exposed to someone who has COVID has remained unchanged. Isolate or quarantine for at least 5 days. Then, once your symptoms are improved, mask for another 5 days. In taking these steps, Ohio has joined many other states and the Association of State and Territorial Health Officials, the Council of State and Territorial Epidemiologists, the National Association of County and City Health Officials, the Big Cities Health Coalition, and the Association of Public Health Laboratories, in assuring that as COVID-19 evolves, so our public health mitigation strategy changes to keep pace. there is an increasing sense that Omicron, in the context of a strong foundation of vaccine immunity, is playing an important role in the evolution of this pandemic to something that will be more endemic, something we can live with without serious threats to our population and our healthcare infrastructure. But we're on the way there. We haven't arrived there yet. Before COVID-19 can become endemic, we need to see substantial reductions in our hospitalizations and case numbers, coupled with more people vaccinated to keep the spread low. Today, more than 6.5 million Ohioans are in fact fully vaccinated, and more than 3 million are boosted. But nearly 40% of eligible Ohioans still aren't. Endemic diseases are all around us, from the common cold to the flu. A pandemic's impact is far-reaching. In fact, COVID-19 killed nearly 8 times as many Americans in 2021 as the flu killed in its 2017-2018 season, which was one of the worst in more than a decade. Epidemiologists consider a disease endemic when it's consistently present year after year and its impact is relatively consistent and predictable. COVID-19 thus far has been anything but consistent and predictable. So we need to continue to work together to reduce the spread of COVID-19, and we need to keep taking steps toward a world where COVID-19 is more endemic than pandemic. Staying up to date on vaccinations, getting boosted when it's appropriate, coupled with the layered prevention strategies my colleagues have referenced, including masking, sanitizing, distancing, testing, staying home when we're sick. These are all ways each and every one of us can help Ohio move in the right direction. Thank you, and we can now take media questions. Michelle.
Thank you, Dr. Vanderhoff. Our first question is from Karina Chung with NBC4.
Thank you, Dr. Vanderhoff. I have a question following up on the rapid antigen testing that the state has committed to buying these next several months. Where are we with the shipment delays, and how soon will we be able to see distribution back in libraries and local health departments?
Well, thank you. Very good question. We are working with the supplier and are anticipating the arrival of 400,000 of our tests. We had ordered over 1 million, and we're hopeful those will be arriving imminently. As we work first to ensure that the tests that are needed by our schools, especially our K through 12 schools, have been allocated. That will then allow us to look and determine how many we can distribute to libraries. But meanwhile, of course, there are a number of other initiatives underway aiming to help with the availability of testing for people all across the country, including the federal government's opportunity for people to order tests that can be sent to their homes. That is something I would encourage people to consider doing. And we, of course, have continued to work very hard to stand up and maintain testing sites in communities all across the state with the help of the National Guard. So we continue to lean into this, and we continue to explore opportunities with other partners regarding how we might bring more testing to the people of Ohio.
Thank you, Dr. Vanderhoff. Our next question is from Andrew Welsh-Huggins with the Associated Press.
Hi there. Thanks so much for doing this opportunity. This is a question for Dr. Kaminsky, but maybe Dr. Vanderhoff could weigh in as well. It has to do with just updating us on the ProLink staffing. Dr. Kaminsky, if you're able, I understand ProMedica has around 50 ProLink staffers, And I was just wondering if you're able to discuss briefly how they're being integrated into the existing staff. Are they adding capacity or just helping you tread water? Do you know how long they'll be there? And do you have any idea where they're coming from? Are these Ohio folks or coming from out of state? Thank you.
Okay, so ProLink is the National Guard, right? That's what you're referencing, correct?
No, I'm referring to the ProLink staffing contract that the state made with the ProLink company. I believe they were providing additional nurses and respiratory therapists.
So the agency example. So I don't know exactly how many are coming from ProLink specifically, but I do know that we have and continue to engage with that agency in addition to other agencies that provide staffing for us. And it's a very dynamic situation based on needs, based on current staffing availability with our full-time employees. But that is something that we have engaged with for a long period of time, all through the course of the pandemic, and trying to supplement existing staffing with agency staffing. And I really just don't have more details on that. And I apologize for not being able to give you more specifics.
Our next question is from Candace Price with WHIO.
Hi, everyone. Thank you so much for doing this. My question is going to be for Dr. Vanderhoff. So we've been seeing with the CDC that just 40% of vaccinated Americans have gotten boosted. And here locally, we're also seeing number of boosted Ohioans steadily decline since December 3rd, which would kind of seem like maybe the boosted effort is losing some steam. So could you talk to me a little bit about the risk of hospitalization and the difference versus those who are fully vaccinated versus those who have been boosted?
Yeah, I'm happy to. So yeah, thanks for that question. First, I think we need to recognize that the primary series provides us with our foundation for vaccine-based immunity. And that foundation of vaccine-based immunity has proven very effective and very durable in terms of protecting us against the most severe outcomes of disease. However, what has been evident is that the part of our immune system that is sort of the first response, that is our antibody response, does wane over time. And it's clear that people who proceed and get a booster when it's time, keep that vaccine up to date, are affording themselves maximal immunity, maximal protection. So they are less likely to become ill with symptoms, and they have even enhanced protection against some of the more severe outcomes of disease. But boosting is particularly important for individuals who may be at higher risk and of greater age. Having said that, the recommendation for boosters for all adults has really reflected the data that has shown that after a certain interval, boosting really does enhance our immune system's ability to provide us with that layer of protection we need. So we continue to strongly encourage people to pursue their booster shot. But the most important step is getting that primary vaccination series going. And we have 40% of the state who still has an opportunity to provide themselves with that level of protection. And let's remember, COVID-19 is here to stay. So we really do need, if we are unvaccinated, to strongly consider getting vaccinated. And again, if our vaccines are not up to date, keeping them up to date with a booster.
Our next question is from Kevin Landers with 10 TV.
Good afternoon, Dr. Vanderhoff.
Afternoon.
You said that schools may discontinue contact tracing, and you said it's become impractical. Why is it impractical now versus a month ago? And why make parents guess who in the classroom is infected if they're not getting daily updates? Thank you.
Thanks. That's a very, very good question. So we have to understand that the Omicron variant is substantially different. It has really changed the complexion and picture of COVID-19. And as we have nationally looked at the best ways to respond and the best ways to keep people safe, it's become clear that with something that is spreading as ubiquitously, as you know, it was something that is literally just about everywhere. The most important steps that we can take are to focus on areas where we're seeing an unusual degree of activity, a cluster of cases, or a clear indications of a localized outbreak, as well as focusing our efforts on environments where we really work very hard to prevent any degree of transmission, many of our congregate care living environments, and intervene rapidly there. The difference that we face now compared to where we were a month ago, we were dealing primarily with Delta, and the dynamics of the Delta variant were very different. Now we're dealing with Omicron, a totally new version of the virus, a new variant, about which we had very limited knowledge. And within a couple of weeks, we've gained enough knowledge to be able to say, this is clearly, with Omicron, the most effective way to go. Now, in terms of safety, the important steps for keeping our kids safe in school are the ones that we have been recommending, advocating from the very beginning. They are getting vaccinated, and then following that vaccination with the added layer of wearing a mask, especially during times of high transmission, which is what we are facing now. We're not asking parents to guess where the exposure might be coming from. What we're advising parents is the exposure is everywhere. So we're asking that they focus on those safety mechanisms that have proven so effective for us, and allowing our public health infrastructure to focus on those parts of the pandemic, those parts of this epidemic in the state of Ohio, that resource is best able to address.
Our next question is from Sara Shookman with WKYC.
Good morning. Just following up again on the changes coming for schools. We've heard from the Summit County Health Department that they have some questions about how this directive is actually put into place, and how are you going to be further advising your county health districts and also the schools themselves to identify such clusters and continue to keep people, as sort of Kevin was alluding to, calm with this change that sort of makes it feel like, I don't know, Omicron is inevitable?
Yeah, thanks for that question. So first, a number of things that are included in that question. The first is the change that we've made for schools is actually a very limited change. It's very focused. And what I want to emphasize is that we continue to advocate and continue to have many schools adhering to the safety mechanisms that have proven to be so effective. Schools actually work as partners with local health departments, and the schools will continue to submit data from the schools to the local health departments regarding cases that they're aware of. But make no mistake, it's the local health departments who have the professionals who work to identify where they are seeing clusters or outbreaks of cases. And of course, they do that in partnership with the schools. So the only thing that we've done as a change impacting the schools is to say, since we are discontinuing the universal contact tracing, there is no need for the schools to be engaging in universal contact tracing. And the reality was that there was virtually no school that was able to universally contact trace students all across their district. So that's the focus change. The important elements of safety, though, remain in place. Our local health departments continue to survey and watch the numbers and watch the locations so that they can engage in appropriate outbreak or cluster investigation, including if those occur in a school. Moreover, mask to stay, test to play remains in place. And of course, that guidance is guidance that has allowed us to safely enable students who may have had contacts, may have encountered somebody with the virus, to be in school safely. And it essentially involves wearing a mask for 10 days after their last day of exposure. But another layer of protection is that we have strongly advised our schools to mask up. We've strongly advised them to ask their students to wear a mask at school. The combination of being vaccinated and wearing a mask continues to be a good formula for keeping our kids safe in school. So none of that has changed.
Our next question is from Pete Grieve with Spectrum News.
Hello. I'm wondering, in light of the news about monoclonal antibodies, two of them losing their authorization, in Ohio, many of the hospitals here had sort of large monoclonal antibody clinics where they were doing those infusions. I'm wondering if you can talk about what's next for those clinics due to the limited supply, and can they use the drug remdesivir in a similar way?
Thank you very much. Great question. So it's absolutely true that with the evolution of Omicron and Omicron's rapid ascendancy, we unfortunately lost the benefit of a couple of our previously very effective monoclonal antibody therapies that were available to our hospitals and actually were available in fairly substantial numbers. As it turns out, the only monoclonal antibody that is effective for treatment for patients in the Omicron era is the monoclonal antibody sotrovimab, which unfortunately nationally is available in very, very limited supply and is allocated to the states in very small numbers. We have worked very closely with all of our monoclonal antibody therapy providers. Remember, this is an IV infusion or IV injection. So we've worked closely with our monoclonal antibody providers to assure that our limited supply is directed to people who are at the very highest risk. But unfortunately, the supply is incredibly limited. Our alternatives include a number of therapeutics. Paxlovid is one, molnupiravir is another, and of course, a third is remdesivir. Now, the federal government is allocating through the states Paxlovid and molnupiravir. And while both of those are available in greater quantities than sotrovimab, they are still in very, very limited supply. And we are working through the same distribution model for these very limited supply therapeutics as we are for sotrovimab. Remdesivir is also a therapeutic that is showing good efficacy against the Omicron variant, but it is not something distributed through the federal government and then through the state. Rather, it is a commercial product. But while there is remdesivir availability, the sky is simply not the limit with that either. So with all of this rolled together, what we've continued to do is to advocate very strongly and work very closely with federal authorities around how the production of these life-saving treatments can be accelerated so that more and more of these very important agents can be made available. But the reality is today, we're looking at very limited supply, but our healthcare providers are very aware of these 4 agents and are working aggressively to make them as available as possible to their patients. And I can pause here. My guests are both physician leaders in health systems, and I'm sure encounter this. I don't know, gentlemen, if there's anything that you would like to add to that.
Sure, I'm happy to go first. Up in Northwest Ohio and ProMedica, we stood up a monoclonal antibody process over a year ago. We've given over 9,000 doses to patients. We think it is a great strategy, not only to help people in need, but also prevention of the strain on the hospital system. So what we're able to do is we're able to adapt and evolve that program that we set up into these other therapeutics that are available. And as Dr. Vanderhoff explained, we certainly wish we had greater availability of all of the options that are out there. So what we've had to do is we've had to risk stratify. As of right now, we actually have all 4 options that Dr. Vanderhoff talked about available in our system. So we have a process for being able to identify those individuals who are at higher risk than others for developing severe disease, and we prioritize them in receiving treatment. So when we look at treatment priorities, we generally consider the oral treatment, Paxlovid, being preferential because it doesn't absorb additional hospital resources, and it looks to be at least as efficacious as preventing severe disease as the other 2. So it's more simpler, and it's more simple on the patient too. They can take it at home and recover at home. We are also giving remdesivir. So remdesivir, Dr. Vanderhoff didn't explain how difficult this is for hospitals, but we actually have to give an infusion 3 days in a row when we're doing this in an outpatient setting. And you can imagine the coordination it takes to do that. But we are doing that because we do have availability of remdesivir for those patients who qualify. The criteria for that drug are actually a little bit more strict than the monoclonals. You can't have certain illnesses, kidney issues play a role, and liver issues play a role. And then also you have to receive that within 7 days. But for those patients who are eligible, again, it looks extremely beneficial. And using those 2 options ahead of sotrovimab, which we want to preserve for those people who don't meet the other criteria, has allowed us to continue to remain operational and deliver all of those therapeutics to patients who are at greatest risk. So we're glad to still be able to do those things, and are looking forward to a time when all those drugs become more plentiful.
And just to say that, the work done in all regions, including ours, in terms of infusing the monoclonal antibodies, for a long time, the limiting factor was the infusion capability itself, because we have more product. Today is the product. And as mentioned, we do have the process if someone's ordered a monoclonal and it's automatically, changed to sotrovimab. We have that process in place. If we don't have sotrovimab, then other options down that list, that NIH4 category list, can be offered, including molnupiravir. And the supplies are very limited. And once again, we have the benefit of talking with all systems together and knowing how much we all have. And as we stand up more availability, we will benefit once again from this sort of significantly massive monoclonal infusion capability we built prior.
Our next question is from Joe Ingalls with Ohio Public Radio and Television.
Thank you, doctors. I want to ask about this new guidance, and also about why you're keeping the rapid test for schools, because now it appears we're hearing from a lot of parents who say that there's a lot of COVID going on in classrooms, and you're not going to have contact tracing at the school level. It's going to be done at the for clusters, like you said, at the Department of Health. So the thing is, wouldn't the test be better in the hands of parents, in the hands of the public, who could use those tests as a way to test children coming out of those schools before they go visit grandma or before they go visit the cancer patient or someone who's at higher risk? Is that priority still the schools, and why keep the testing in the schools at that point?
Well, thank you very much for that question. It's actually one that we've asked ourselves and are in the process of evaluating as we speak. We're looking very closely at what is the impact, what is the efficacy of the approach of directing rapid testing towards schools versus how does that compare with the impact of what we've been doing, for example, with community distribution through local health departments, libraries, et cetera. And don't really have the answer to share with you at this moment, but anticipate we will very soon. And we will pivot as needed to assure that our limited supply is going to best effect. But one of the priorities that we have had, whether we're talking about testing or not, is of course keeping our students in school. There's just a vast array of data and information now that shows that that is the best place for our students, that it is a very, very serious concern when we aren't able to do everything we can to keep them there. But you're right, given the shift in the dynamics of this virus, it may be that testing is best deployed more into the community. And we hope to have that answer very soon. And if needed, when these supplies arrive, we'll pivot accordingly. So it's a very dynamic situation.
Our next question is from Laura Hancock with Cleveland.com.
I was just wondering if you could provide some examples of what a cluster would be. I mean, is there a certain percentage of the school that has to be sick, or is it like a certain percentage of the classroom? Like, what does a cluster look like? I'm just thinking right away of some of these places, rural Ohio, where they're kind of denying COVID, and maybe this would be an opportunity for them to just quit, being vigilant about it.
Yeah, certainly that would be disappointing if people no longer were vigilant about COVID-19. No, as we look at the issue of a cluster, there's really quite a bit of judgment that's involved, and that's why we engaged our local health departments as being the local experts who will work very closely with the schools in making that assessment and determination. The fact is, it's very hard to describe in any other way because our schools are so different. So, if you have 10 cases in a very small school, that looks a whole lot different than 10 cases in a very, very large school or large district. So there's no hard and fast number, but it is something that in partnership with our local health departments, we're confident that our ongoing epidemiologic surveillance will help us to identify. And then we've asked the schools to work collaboratively, cooperatively with the local health departments when those concerns are identified.
Our next question is from Spenser Hickey with Hannah News.
Thank you. You've talked about the level of hospitalizations in some regions of the state. I was wondering if you could discuss how it's going in Central Ohio specifically.
Yeah, I'd be happy to. So as we look at the numbers in Central Ohio, we are seeing that the case numbers are beginning a downward trend. And likewise, in Central Ohio, we're seeing our hospitalizations begin to head in that downward direction. Now, it's not the precipitous or as sustained a decrease as we've seen in other locations, certainly not as sustained as we're seeing for the last couple of weeks up in the Cleveland area. But it is beginning to point in that favorable direction. So we're cautiously optimistic that Central Ohio may have made the turn towards this headed into a decline, which of course is encouraging.
Our final question of the day is from Maya Belay with Fox 8.
Hi, Dr. Vanderhoff. I'm just
Hi.
wondering, can you explain the difference between the universal contact tracing versus cluster contact tracing? And then also I'm wondering, a lot of schools, at least in our area, are stopping their mask policies. Any concern that the practice being dropped paired with the recommendation to change the way cases are traced could risk more outbreaks in schools?
Thanks. The practice of universal contact tracing is one that, in fact, nationwide, and the reason you have these national bodies of health leaders advocating this kind of pivot and multiple states moving in this direction is the reality that when you have something that is as rapidly contagious and has such a relatively abbreviated clinical time course as the Omicron variant of COVID-19, it's nigh unto impossible to universally contact trace people in a manner that would have a timely enough impact to make a difference in terms of community spread. Rather, what does work is the kind of focused, almost sort of SWAT team-like intervention that we're pivoting to and have advocated. And moreover, is essentially at a practical level what in so many parts of the state is in fact what people have had to do just because of the sheer numbers of cases. In terms of your question about safety, our message has not changed. We've continued to advocate first, begin with vaccination. Vaccination is the best way to provide a strong layer of safety for our students and our teachers. Add to that masking, and we've continued to advocate masking at least until we see the community rates of COVID-19 drop to much lower levels, signaling that the risk of encountering COVID-19, either in the community or in school, is much, much lower. We continue to encourage that. It's simply premature. Look at the numbers. While we are pointed in the right direction, we're still at very, very high levels. And so we've been making those recommendations. We'll continue to make those recommendations. It is, of course, up to communities and local school districts to make the determination about what they'll do. But our recommendation remains unchanged in terms of the safety measures that we're advocating. I don't know if either of my colleagues have anything to add to that as healthcare providers, and particularly Dr. Fagan in your role as a medical director for a health district.
You said it very well. Everybody do their part. This thing's not over yet. We are learning to live with it, and just be kind and be thoughtful. And everybody do your part as a community. And we meet with, as all health districts do, the superintendents on a weekly basis and have these conversations. And they're not easy, but we're just trying our best.
Nothing to add on my end. All well said.
Thank you to all of our guests today. Dr. Vanderhoff, do you have any closing remarks?
Again, thank you so much to my guests who joined today. Really appreciate your insights and your contributions. Thank you also to all of you from the press for your excellent questions and your continued concern for the state and the communities that together we're serving. So thank you.